So what should we do with patients who had a really good response to a targeted therapy and now are starting to show signs of resistance? I think that the paradigm for how we conceptualize the treatment options for these patients are really changing, and they're changing a lot based on common shared experiences and retrospective data. We don't have as much of a prospective set of trials to base an evidence base for which to make these recommendations yet, although I think that's coming. I think a couple of themes that come out of how to treat patients with acquired resistance are: 1, get a repeat biopsy; 2, think about treatment beyond progression; and 3, think about aggressively treating local progression. And so this idea of local progression, if you have a patient who really has stable disease in almost all their locations but may have one focus of trouble, that's a situation where I think a lot of retrospective case series have shown that patients can remain on their targeted therapy for a long time if you aggressively go after that area. Most commonly with radiation, that's the most practical for patients with advanced disease. Occasionally surgery is something that could be explored as well. I think that if possible, it's a good idea to try and do a biopsy of the area before you radiate it, but this is increasingly a common strategy for patient care. What about patients who are progressing in a more diffuse way? There, I think we're realizing more and more that a lot of these patients progress slowly, and with careful watching, it's okay to keep them on their TKI, watch them carefully, maybe even more frequently than you were before. If you were doing scans every 3 months, think about going to every 2 months just to keep a closer eye. But again, retrospective series have showed that patients can often go 4, 6, 8 more months on their TKI before they have sufficient growth to really demand a change in therapy. There are some patients who progress more quickly, and that's what you want to do, the careful surveillance to make sure you catch those patients. When patients are progressing to a point where you really do need to add in some other kind of therapy, I think that there is a growing argument to be made for continuing the TKI and adding in something else like chemotherapy to it. The reason for this is that about a quarter of patients who have an oncogene addiction will actually flare. Their disease will get rapidly worse when you take off the TKI. And this is a minority of patients. 3/4 of patients this won't happen. But in the quarter of patients where there is a flare, it can be serious. It can be life-threatening. And so there are some prospective trials looking at the strategy of taking off the TKI and switching to chemo versus keeping on the TKI and just adding chemo. But until we have the answer to that, my general practice has been to continue TKI and add in chemotherapy.